Good evening. Thank you for joining us for this session. The talk is about diabetic neuropathy, clinical manifestations, diagnosis, and management. I'm Dr. Bien Matawaran. I am an endocrinologist. So the aim of today's presentations are to be aware about the importance of diabetic neuropathy. Hopefully, you'll be able to learn about the pathophysiological processes behind the condition. After this presentation, your knowledge about available neurological tests will be refreshed and that you will have an overview of the available treatment options for diabetic neuropathy. So we all know that diabetes is on the rise. This is data from the International Diabetes Federation Diabetes Atlas of 2019. As you can see, globally, particularly in the Western Pacific region, whereby the Philippines is included, there is a 31% increase in the prevalence of diabetes mellitus. And worldwide, we will be later seeing a 51% increase in the number of persons with diabetes from 463 million in 2019 to as much as 700 million by 2045. So it's very important that we do diagnose patients with diabetes and eventually arrive at a very important treatment plan to eventually prevent the occurrence of complications. Mainly because there are a lot of complications, the vascular complications in patients with diabetes. We are all aware of the micro and macrovascular complications that is part of diabetes mellitus. So microvascular complications, of course, include diabetic retinopathy, diabetic nephropathy, and diabetic neuropathy, which can affect mostly quality of life. While macrovascular complications, particularly stroke, ischemic heart disease, peripheral artery disease, and even, of course, MI, would eventually, of course, affect not just quality of life, but eventually mortality and death. This is a short review of the natural history of type 2 diabetes. So in this particular slide, you will see that fasting blood sugar, as represented by the line in gray, slowly increases from normal glucose tolerance to pre-diabetic level, and eventually, at this particular point, clinical manifestations of diabetes mellitus with an elevated fasting plasma glucose. Part of the more common pathophysiologic mechanisms of type 2 diabetes, of course, is the effect in insulin sensitivity and insulin secretion. So insulin sensitivity, the opposite of which is insulin resistance, usually occurs in those patients predisposed to develop type 2 diabetes. As you can see, a patient is sensitive to insulin. However, when they do develop or progress to type 2 diabetes, you slowly see the decline in the sensitivity to insulin, or what we call insulin resistance. On the other hand, for patients to maintain their normal blood sugar, what happens is that they compensate by increasing insulin secretion, as represented by the yellow line. So in here, patients with pre-diabetes may still have a relatively normal or relatively low blood sugar, and yet there is continued insulin hypersecretion and continued reduction in insulin sensitivity. So that at threshold in this particular part of the graph, you now see increasing insulin resistance or decreasing insulin sensitivity, as well as a gradual reduction in insulin secretion. Okay? And as you can see, likewise in this illustration, that complications occur usually at diagnosis, but for some, they usually occur even at pre-diabetes stage. And this, of course, includes what I mentioned earlier, both micro and macrovascular complications. So for this session, we'll be talking mostly about the microvascular complication, which is neuropathy. And unfortunately, neuropathy can be seen in patients with diabetes, and the risk for neuropathies, the manifestations may either be distal symmetric painful neuropathy, your painful diabetic symmetrical polyneuropathy, and even your cardiovascular autonomic neuropathy, that was seen in the CHORUS study. So the risk for neuropathies, okay, diabetic sensory polyneuropathy and cardiovascular autonomic neuropathy is already increased in pre-diabetes, especially in persons with combined IFG or impaired fasting glycemia and IGT or impaired glucose tolerance, as you can see in this part of the illustration. And the numbers are fairly similar to those patients already with known diabetes mellitus. So that diabetic neuropathy should not be considered as a late complication, but rather an early complication of type 2 diabetes. So in a study looking at the prevalence of diabetic neuropathy, it is seen as the most frequent complication among patients that were surveyed in the ASEAN region. As you can see, represented by the red square, 58% of adult diabetic patients in the Philippines were diagnosed with diabetic neuropathy, and this was based on nerve conduction studies. So that's more than half of those surveyed diabetic had prevalent diabetic neuropathy in this study. And we are well aware that this is because of alteration in carbohydrate metabolism. We're well aware that diabetes and hyperglycemia is due to an altered metabolic pathway, particularly due to abnormalities in carbohydrate metabolism. Normal metabolism will eventually yield upon entry of glucose in the cell, formation of your pyruvate. Okay, and this pyruvate will eventually enter the Krebs cycle, as you can see here, because pyruvate is the product of aerobic glycolysis, and this is that step, aerobic glycolysis. And this pyruvate will eventually enter the Krebs cycle to eventually form energy or ATP, okay, that will supply the cells with energy. So the left side part of the glycolysis is via your anaerobic glycolysis, the product of which is lactic acid. So as you can see here, in patients with a lot of substrate glucose, you expect an activation or hyperactivation of the Krebs cycle, thus producing more energy. But in response, there's also a production of a lot of reactive oxygen species as well as oxidative stress. So to illustrate the pathogenesis of diabetic macrovascular complications, as we see here, you have food, okay, that will enter the cell. It will be manufactured or dealt with by the mitochondria, which we said is the power plant or the powerhouse of the cell that will eventually produce energy. So if you have hyperglycemia, you will be overloading the system, thus producing reactive oxygen species. So this is why there were activation of alternative glucose metabolizing pathways, as you can see here. And these include your polyol pathways, your hexosamine pathway, your protein kinase C pathway, and even your age or your advanced glycated end product pathways. And all of these pathways will actually increase oxidative stress, insulin resistance, inflammation, and vascular damage that will eventually cause the diabetic tissue damage in our patients. So as you can see here, oxidative stress is very important because of that increased activation of glucose metabolic pathways. And this will eventually now cause the complications of diabetes. And of course, this includes your diabetic neuropathy. There are several ways of classifying or characterizing diabetic neuropathy. The one in the left, that's letter A, is the most common manifestation. And this is your distal symmetric polyneuropathy or your stocking and glove phenomenon. So diabetic distal symmetric sensory motor polyneuropathy is the most frequent clinical manifestation, which makes up 75% of all diabetic neuropathies. In approximately 50% of cases, coincides with autonomic neuropathy and can affect nerves that control both sensory or motor function. It spreads from distal, so that's why we call it stocking and glove phenomenon, to the proximal, wherein nerve fibers that are far from the center of the body are affected first. So again, we call that stocking and glove pattern, not the glove and stocking pattern. So as the disease progresses, nerve damage spreads in the direction of the legs and the hands, and most of the time distribution is symmetrical, typically on both sides. So this is just to illustrate some paradox with regards to the presentation of distal symmetric polyneuropathy, because you may have what you call positive or plus symptoms as well as negative or minus symptoms. So when we talk about plus symptoms, this will include paresthesias, burning pain, and numbness, and of course pain. And this will translate to a reduction in quality of life. Minus symptoms will be inability to appreciate hot and cold, no reduction in temperature and pain sensation. And these two manifestations will increase your risk for diabetic foot syndrome, or what we call loss of protective sensation, or LOPS. So this characterize patients with distal symmetric polyneuropathy. And the prevalence again in patients with diabetes may be as high as 30%. Okay. So in another study, this is done in Germany, wherein they did a nationwide educational initiative in Germany and looked at the percentage of undiagnosed excuse me, distal symmetric polyneuropathy. As you can see represented in this graph, you see patients with distal symmetric polyneuropathy, those with both painful and painless distal symmetric polyneuropathy. And they noted that in patients who were not diabetic to start with, no, they were non-diagnosed diabetic, you will see that the number or the percentage of patients with undiagnosed diabetes but with distal symmetric polyneuropathy is considerable. No? In about 70% of cases, distal symmetric polyneuropathy was previously undiagnosed. In this study, wherein they looked at 3 neurological tests, tuning fork, 10-gram monofilament, and tip term, you will see that they may be seen even for those initially non-diabetic individuals. Another way of classifying neuropathy in patients with diabetes is to look at what are the affected nerve fibers. So you may have large or small nerve fiber function. So you may have large or small myelinated or thinly myelinated or unmyelinated nerve fibers. So as you can see here, motor affectations will most likely affect the myelinated large nerve fibers. As you can see here, control or motor control will be affected. Touch, vibration, position, and perception may affect myelinated large to small fibers as you go along this illustration. So again, this is one way of classifying diabetic neuropathy. So that is important mainly because when you do examine or you do your neurologic test to establish diabetic neuropathy, you of course test and try to find out what particular nerve function is affected. So for example, when you do the 128 hertz tuning fork, no, testing for vibration senses, now you'll be testing large nerve fibers. Similarly, your 10-gram monofilament test, which will test pressure sensation, will also test for large nerve fiber function and even your muscle reflexes. So that's 3 ways of examining your for diabetic neuropathy. How about small nerve fiber function? So the pinprick test, neurotips, or your pain sensation, as well as your temperature sensation using a tip term, will eventually take note of small fiber affectations. So with that being said, it is thus very important to screen for diabetic neuropathy. And the recommendations by the American Diabetes Association include that all patients should be assessed for distal symmetric polyneuropathy starting at diagnosis of type 2 diabetes. So even at the first visit, once you see a diabetic patient, then you have to screen him or her for diabetic neuropathy. Or for type 1 diabetics, 5 years after the diagnosis and at least annually thereafter. Screening patients with prediabetes who have symptoms of distal symmetric polyneuropathy should be considered as well, as we've learned from the CORA study, because up to 50% of cases with DSPN may be asymptomatic, and that you have to bear in mind. So that is important because there is progression of this symmetric neuropathy. As you can see in this illustration, it is basically a spectrum. As represented by the yellow part of the pie chart, these are normal function versus the gray part, which is reversible component of abnormality, while the lighter gray part is the irreversible component of abnormality. As you can see, it is progressive. It is a spectrum. So the therapy, the success depends on the amount of reversible abnormalities. So it's really better early than late now in the management of diabetic neuropathy, because the earlier therapy started, the better will be the eventual outcome. So if we look at the cornerstones of distal symmetric polyneuropathy treatment, we have three very important items to think about. One is optimization of blood glucose control and management of additional risk factors. Two is the blockage of pathogenic glucose metabolizing pathways. And third is symptomatic treatment, especially of neuropathic pain. So when we talk about optimization, as you can see here, so that would include, of course, lifestyle intervention, smoking cessation, reduction in alcohol intake, management of hypertension, foot care, etc. So that is pillar one in the management of DSPN. So how important is blood glucose control? So there are several studies looking at intensified blood glucose control in type 2 diabetics now with regards to this particular output. So you have the UKPDS, as you can see in the list on the left, the Kumamoto, the VADT, the Advanced, the Accord, the Barry, and Dishon. So basically, these studies compared a higher versus a lower HbA1c or tighter glycemic control and looked at microvascular complications, which for most part actually improve with intensive glycemic control, particularly for retinopathy and nephropathy. But this was not as consistent for patients with neuropathies. As you can see here in the illustration, most are non-applicable, or there were no significant reduction in the occurrence of neuropathy symptoms or improvement in neuropathy symptoms. So the tight glycemic control showed no clear benefits with regards to type 2 diabetes compared to the other microvascular complications when we talk about glycemic control. How about symptom relief, symptomatic treatment of neuropathic pain? So there are a lot of recommendations with regards to international guidelines on what to give for patients with a symptomatic or painful neuropathy. As you can see in the box there, you see amitriptyline, duloxetine, pregabalin, and gabapentin as recommended treatment by different international medical guidelines with regards to painful diabetic neuropathy. There are also medications that can be considered for comorbidities and their contraindications. So for example, most of those drugs that I mentioned earlier, they have specific contraindications for patients, for example, who are obese, those with depression, etc. However, if you look at pathogenesis-derived therapy that we'll be discussing in detail later, you will see that they are relatively safe with regards to drug-drug interactions, as well as relatively safe to the corresponding comorbidities of these patients already suffering from neuropathy. So the third pillar of treatment, as I've mentioned, is the blockage of pathogenic glucose metabolizing pathway. And we will go back to the pathways I've showed you earlier. So we've identified that these are mechanisms causing diabetic neuropathy, so that stopping some of these alternative glucose pathways may be beneficial, as well as, for example, one pathway is a reduction in oxidative stress that is a trigger for most of the microvascular complications of diabetes. However, we also see that there is low activity of transketolase in thiamine deficiency, which may also produce associations to diabetic neuropathy, so that a drug that will activate your transketolase, or what you call a transketolase activator, like your venphotiamine, may be helpful, or something that will address oxidative stress, and these are your very strong antioxidant or your alpha lipoic acid. So that the treatment algorithm as proposed by Ziegler for diabetic neuropathies, particularly for distal symmetric polyneuropathy, of course, include adequate clinical diagnosis with or without presence of neuropathic symptoms, we still have to initiate lifestyle modification, control of cardiovascular disease or other risk factors, assessment for comorbidities, and potential for drug interactions. For asymptomatic and symptomatic non-painful diabetic sensory polyneuropathy, you will see that pathogenesis-derived treatment may be an option. Okay, it goes without saying that for painful distal symmetric polyneuropathy, analgesic treatment may be important. But going back to pathogenesis-derived treatment, so this will include your alpha-lipoic acid, your venpothiamine, and your actovegin. Okay, so basically, for analgesic treatment, there are a lot of recommendations, and that would include pharmacotherapy, which includes your duloxetine, your tricyclic antidepressant, your pregabalin, and your gabapentin. Second-tier recommendation for analgesic treatment include your capsaicin, your tramadol, your non-narcotic analgesic, or strong opioids, and even sodium channel blockers. However, there are also non-pharmacologic treatment like your TENS, your high-tone therapy, acupuncture, physical measures, and psychological support. And luckily, there are recommendations that would say that combination therapy may be needed. Okay? So just an FYI. So what's in a name? Okay, so we have to go here because I've been showing you some terminologies that you may not be quite familiar with. So basically, what's in a name? So acetaminophen, as you all know, is called in other countries as paracetamol. While glyburide is a sulfonylurea that we give for someone with diabetes, is also known as your glibenclamide. And of course, your thiamazole, which is also a drug for hyperthyroidism, is the same as your metimazole. So why is it important? Because for today, we'll be talking about a two set of medications. So alpha lipoic acid is basically or also known as your thioctic acid. So as you can see in the illustration on the left, so that is lipoic acid or thioctic acid. The IUPAC chemical name is your 1,2-dithiolane 3-pentanoic acid. You see there's an 8-carbon fatty acid, basically a fatty acid that contains your thiolol or your sulfur-containing moiety. Okay, so it has a unique amphiphilic character, meaning it has both an hydrophilic and a hydrophobic property and can elicit its action in both cytosol and plasma membrane. Okay, so that's your alpha lipoic acid or your thioctic acid. So what is important with this particular medication? So we're well aware, as we saw earlier in the pathophysiologic mechanisms, the relevance of oxidative stress in diabetic neuropathy. So in this slide, you see that oxidative stress is enhanced in patients with diabetes before the development of distal symmetric polyneuropathy, but to an even higher degree in those with manifest distal symmetric polyneuropathy. So again, oxidative stress is the main driver. So that a universal antioxidant may be given or may give benefit in those patients suffering from severe oxidative stress. And alpha lipoic acid suppresses oxidative stress by direct and indirect mechanisms, by scavenging free radicals, reduction of oxidized forms of other antioxidants, chelation of divalent redox active transient metal ions, and they also function as cofactors for several mitochondrial enzymes, which are part of the mitochondrial oxidant system. So that shows you the importance of what we call antioxidant. So this is one study, which is a dose-finding study using intravenous alpha lipoic acid. This is the Aladdin 1 study. As you can see, they measured total symptom score using a questionnaire from baseline to day 19, whereby alpha lipoic acid at doses of 1,200 milligrams per day in blue, at 600 milligrams per day and at 100 milligrams per day versus placebo showed a reduction or as much as a 30% reduction of total symptom score after 19 days, particularly with alpha lipoic acid at 600 milligrams daily. Okay? So the Sydney 2 study is likewise a dose finding on oral treatment. So they again measured your total symptom score from baseline to 5 weeks after. Again, if you look at the different doses at 1,800 milligrams, at 1,200 milligrams, and at 600 milligrams versus placebo, you will see that with the 600 milligram oral treatment, produce a more than 50% reduction in total symptom score after 5 weeks of treatment. And this is per ORM versus per IV. In the Nathan 1 study, looking at the long-term effects on neuropathy, on neuropathic deficits, you will see that study in patients with mild to moderate, mainly asymptomatic DSPN showed after 4 years improvement. So what you see is that with that treatment at 600 milligrams of alpha lipoic acid, more patients responded. Okay, and there were patients that were unchanged, meaning they didn't get worse. And if you look at the progressors, those patients which get worse, it was a lot lower in those patients already on alpha lipoic acid versus those who were not. Okay. In the post-hoc analysis of the Nathan 1 study, wherein they looked at particular characteristics of patients that improved or worsened, they noted that alpha lipoic acid is particularly effective in patients with longer duration of diabetes and neuropathy, and in patients who already develop more severe stages of diabetes, neuropathy, and cardiovascular disease. If you look at different randomized double-blind trials with alpha lipoic acid in distal symmetric polyneuropathy, so there are evidences of benefit, no, once they're given either per ORM or per IV, looking at this different systematic review. So in the systematic review and meta-analysis, as represented by IV and oral treatment in orange, it shows that oral alpha lipoic acid at 600 milligrams once daily had effects on diabetic peripheral neuropathy symptoms identical to those IV preparations of alpha lipoic acid. So pain reduction was likewise a pattern or was a parameter with regards to differences in treatment. So as you can see, it's represented by the second item in this forest plot. Treatment with alpha lipoic acid showed high chance of more than 50% pain reduction. What is also important, because I've mentioned earlier in the proposed algorithm for the treatment of diabetic neuropathy, that we can combine treatment. And this is a very nice pharmacokinetic study looking at combination of pregabalin and alpha lipoic acid among healthy male volunteers. So this is an open label randomized treatment crossover to achieve steady state concentration. So these are patients given pregabalin at 300 milligrams daily, thioctic acid or your alpha lipoic acid at 600 milligrams daily, and the combination of the two treatments. As you can see in this illustration whereby they looked at the concentration of both pregabalin and thioctic acid, there was no difference even though you do combine these therapies. Okay, as given alone in yellow, as well as given in combination in blue. There was no difference in the pharmacokinetic interaction of the two drugs when given simultaneously. How about clinical parameters with regards to switching therapy? So these are patients, observational study with painful diabetic symmetrical polyneuropathy treated with 600 milligrams of alpha lipoic acid per ORM during a period of 5 years. As you can see, more than 443 treated patients after 5 years were either shifted to gabapentin or eventually not treated at all. So what happened was, for those patients, 45% on pregabalin had to stop taking the drug due to intolerable side effects. So with pregabalin, there were higher rates of adverse events, higher daily total cost of treatment. Okay, versus those patients who were untreated, they immediately developed neuropathic symptoms after switching or stopping their alpha lipoic acid or thioctic acid as 2 weeks after the end of treatment. So that shows you the value of switching as well as stopping the medication. So this is again alpha lipoic acid versus gabapentin or no treatment at all. This observational study, on the other hand, was more mechanistic, no, more objective, because they looked at electromyoneurographic examination. So these are patients treated with pregabalin, benfotiamine or alpha-lipoic acid depending on the clinical picture, and they looked at electrophysiologic re-examination after 3 months. So if we look at the change in sensory nerve conduction velocity, so this is more objective, you will see that there was improvement after 3 months of therapy for those patients given alpha-lipoic acid at 600 milligrams per day, benfotiamine at 600 milligrams per day, and there was actually worsening or non-recovery for those patients not given treatment, as well as for those patients given gabapentin. So the study showed that alpha-lipoic acid and benfotiamine had a positive impact on the recovery of the nerve pathophysiological processes, whereas gabapentin had no impact on the recovery, similar to the control group, which was not given any treatment. There were studies also on quality of life. They looked at several questionnaires: the work disability score, social life disability score in blue, family life disability scores. As you can see, at baseline and 40 days after, there was reduction in neuropathy symptoms that was accompanied by an overall improvement in patients' quality of life when they were given alpha-lipoic acid. So for consideration in clinical practice, make sure that alpha-lipoic acid should be taken on an empty stomach in order to achieve maximum absorption. So the recommendation is 30 minutes before breakfast once a day. Remember that it is a metal chelator, so that it should not be administered at the same time as metal compounds like your iron, magnesium preparations, and even your milk products, because they will be chelating or binding these metal ions. Alpha-lipoic acid may have insulin mimetic effect by directly and indirectly interfering with the insulin signaling cascade. So insulin mimetic, it can produce a reduction in blood sugar. So monitoring of blood sugar, particularly at the beginning of treatment, is important. The dose of insulin or oral anti-diabetic drugs might be adjusted because of this additional effect of your alpha-lipoic acid. So in summary, hopefully I was able to show you that diabetic distal symmetric sensory motor polyneuropathy, or your DSPN, is the most common clinical manifestation, accounting for about 75% of diabetic neuropathies, which can be already detected even in the pre-diabetic stage. So it is basically an early rather than a late complication of diabetes mellitus. Treatment of distal symmetric polyneuropathy should multimodal, considering the individual risk factor. Pathogenic treatment and pain management using pharmacotherapy or combinations if required, as well as non-pharmacologic options, particularly for alpha-lipoic acid or thioctic acid. So thioctic acid, oxidative stress plays a major role in the pathogenesis of distal symmetric polyneuropathy, and that several randomized controlled trials and meta-analysis confirm benefits of alpha-lipoic acid on neuropathic symptoms in patients with distal symmetric polyneuropathy, as it acts as a universal and potent antioxidant. Also have to remember that it is suitable for long-term pathogenic treatment of distal symmetric polyneuropathy and can be safely combined with symptomatic analgesics like your pregabalin. So with that, thank you very much for your attention.